This video is going to talk about the adaptations of cellular growth and differentiation. So, anytime a cell is exposed to some sort of stressor or change, it can adapt to whatever situation it's in. So, there's four main types of adaptations. You have hypertrophy, hyperplasia, atrophy, and then metaplasia. So notice that some of these words have similar parts to them. So first of all, the two words on the left, hypertrophy and hyperplasia, those both have hyper in them. So when you see hyper, think a lot of or more or bigger, and then trophy is in two of them. So trophy is in hypertrophy and atrophy, and this is referring to the size of the cell. So hypertrophy, we just said hyper is more or bigger, and then trophy is talking about the size. So hypertrophy is going to be bigger cells, and then atrophy, this is going to be smaller cells. And we'll get into more details on each of those. And then the last thing that's common between these, notice that hyperplasia and metaplasia both have plasia in them. So plasia is referring to growth. So hyper, we said it's more or a lot of, so that's a lot of growth. And metaplasia, meta is referring to a change, so this is going to be a change in growth of the cells. Okay. So hypertrophy, like we said, this is going to be an increase in cell size. And if you're increasing a bunch of cells, if you're increasing their size, that's going to then increase the size of that tissue or that organ. So why do you think you might be doing this in the body? So take a second, kind of pause, and think about a situation where you might need to make a tissue bigger. So there are going to be some times where this is a normal physiological process, where some cells and therefore tissue or organ need to get bigger for a normal physiological reason. And then there's going to be some times where it's a pathological reason. So there's some sort of pathology or something wrong going on, and that's going to cause these cells to have to adapt and get bigger. So the first one we're going to talk about is your physiologic hypertrophy. So this is just going to be normal physiologic reaction to something. So a good example is skeletal muscle. So think about when you go to work out and you want to get your muscles bigger and stronger. Well, anytime you're putting an increased load or weight on these muscle fibers, they're going to respond by getting bigger or hypertrophying. So this is skeletal muscle, and you can see that some of the skeletal muscle fibers, like here and here and here and here, these are all very big. Okay, so these two arrows are pointing to bigger skeletal muscle fibers, whereas these two arrowheads, these are pointing to these smaller muscle fibers. So these are normal skeletal muscle fibers, and then these are bigger, so these are hypertrophied skeletal muscle fibers. So usually this is going to be due to an increased workload. So if you're going and you're lifting weights, you should be increasing those weights over time. That way your muscle cells keep having to adapt and grow bigger or hypertrophy. So this is just a normal response. This is not pathologic. This is just physiologic hypertrophy. But if you have something else going on, you can have pathologic hypertrophy. So a classic example of this, we were just talking about skeletal muscle. Think about cardiac muscle. So cardiac muscle cells are still muscle cells, but so if you put an increased workload on them, they're going to respond by getting bigger, just like your skeletal muscle did when you went to the gym, right? So you can have, if you're an athlete, you can just have normal physiologic hypertrophy of the cardiac muscle, which can be healthy to a certain extent. But if you have some sort of underlying pathology that's putting an increased stress or workload on the heart, you can get pathologic hypertrophy of the cardiac myocytes. So a good example of this is if you have an increased afterload on the heart. So this can be for things like atherosclerosis, or the example I'm going to include is a stenotic aortic valve. So here, if you have the aortic valve here and it is becoming stenosed, what's happening is it's essentially like closing, and it makes the blood, well, stenosed means narrowing, so it's closed or narrow. And so if you're putting that extra stress on the left ventricle normally just pushes the blood through the aortic valve, right? But if that valve is now stenosed, the left ventricle is going to have to work harder to push that blood through there in order to go out to the aorta and then supply the rest of the body. So over time, if you have this stenosed aortic valve, what's going to happen is your left ventricle is going to get thicker. So you can see that on here. This is now a hypertrophied left ventricle because it has now compensated or adapted and gotten bigger. So each fiber has now gotten bigger so that it can generate enough force, contractile force, to push the blood through the stenosed aortic valve. So what that looks like grossly, this is a cross-section of a heart, and you can see that this would be your left ventricle, and look how thick this wall is. This is abnormally thick. Versus the right side, this is actually a little bit abnormally thin. So over here, where these cardiac myocytes have gotten bigger, this is hypertrophy. Same thing here. This is another cross-section showing you how thick this left ventricle has become. And then this is a different type of section so that you can actually compare the two next to each other. So this would be your septum here, and then your right ventricle over here. That's fairly normal-ish, a little bit thin, and then your left ventricle wall over here is very thickened and hypertrophied. So this is a fresh specimen. This is one I had a while back, and you can see right away that this heart is very big. It's got this kind of globus appearance, and so when we cut through this, what you see is this. So this is a cross-section of this heart, and you can see this would be your right ventricle, and then on the left ventricle over here, look how thick this wall is. So this is both hypertrophied and dilated, which is why it has this globus appearance. But what we're focused on for now is this hypertrophied or thickened appearance of the ventricle. So that's what it looks like grossly. And then histologically, what you're going to see is each cell is getting thicker, or it's getting bigger or hypertrophying. So on the left here, these are normal cardiac myocytes. You can see that the fiber is just a little bit wider than the nucleus, versus if you compare these over here, look at this fiber over here. So here's your nucleus, and then look how wide that fiber is in comparison. So sometimes it can be hard if you're just looking at, like, say you hide this side. If you're just looking at this, it's hard to tell if it's hypertrophied or not if you don't have anything to compare it to. But remember that the normal cardiac myocyte, it shouldn't be that much thicker than the nucleus. And so if you see something like this, that is hypertrophied because it is a lot thicker than it should be, even if you don't have anything to compare it to. So that's hypertrophy. So we had physiologic, the example was skeletal muscle, and the pathologic was the cardiac muscle in response to something like an aortic valve stenosis. But it can be caused from a lot of different reasons, anything that's putting an increased stress or workload on that heart. Next, we have hyperplasia. So remember, hyper is a lot or too much or more, and plasia is growth. So this is an increase in cell number. So it's really important to understand the difference between hypertrophy and hyperplasia. So hypertrophy is increase in the cell size. You are not increasing the number of cells. It's the same number of cells. It's just that each cell is getting bigger. Whereas hyperplasia, you're actually increasing the number of cells. So how does the mature cells actually proliferating? So sometimes this is just the cells undergoing mitosis. Other times it can be increased output of new cells from stem cells. It just kind of depends on the tissue. But for the important part for now is to understand that it's an increase in the cell number. So how does this happen? Well, sometimes it will just be the mature cells that are already there undergoing mitosis, and other times it will be an increased output of new cells from tissue stem cells. It really just kind of depends on the situation and on the tissue. So for now, before we get into the organ systems, for now, just understand that hyperplasia is an increase in cell number. So just like with hypertrophy, with hyperplasia, you can have normal physiologic hyperplasia, and you can have pathologic hyperplasia. So physiologic hyperplasia is an increase in the cell number from some normal stressor. So for example, during pregnancy, a woman's breast will get bigger. During the menstrual cycle, the endometrium will naturally get thicker. Those are normal physiologic hyperplasia. Another example is if you get a liver transplant. It's well known that livers can regenerate, right? And so if you get a liver transplant, those cells are undergoing normal physiologic hyperplasia. So if you cut off part of the liver is going to respond by regenerating. So that's a normal physiologic hyperplasia. Whereas pathologic hyperplasia, this is going to occur due to some sort of abnormal stressor. So an example is an adrenal gland. So think about the pituitary gland. The pituitary gland releases a lot of different hormones. So if you have let's say a pituitary adenoma or a benign tumor of the pituitary gland, one of the things that can happen is you can secrete too much ACTH, which is adrenocorticotropic hormone. And adrenocorticotropic hormone goes and it acts on the adrenal cortex to stimulate it. So normally, the normal physiologic process is that, yes, ACTH is released by the pituitary, which stimulates the adrenal cortex. But in this case, the pathology is that you have a pituitary adenoma or a tumor that is causing too much ACTH to be released by the pituitary. That is then going to cause pathologic hyperplasia of the adrenal gland, specifically of the adrenal gland cortex. Another example is proliferation of the endometrium due to a prolonged estrogen stimulus. So you can get pathologic hyperplasia of the endometrium, but you can also have that normal physiologic hyperplasia of the endometrium. So it just kind of depends on the situation. So the adrenal gland that I mentioned, here's a good example of that. So this is a case I had a while back. This is just a normal looking adrenal gland. So notice that your adrenal cortex is the bright yellow here. It's very thin, it's nice and uniform, and then this kind of like tannish to brown in the middle, that's going to be your medulla. So all of this yellow is the cortex. So that's normal for comparison. And then this is an abnormal one. So here you can see all of this bright yellow is your adrenal cortex, but then look right here. This is an overgrowth of adrenal cortical tissue. So this is an adrenal cortical adenoma here. So you can clearly see that there's an overgrowth of this, and this is pathologic hyperplasia. Here's another example. So this is more diffuse hyperplasia of the adrenal cortex, and this is what it looks like histologically. So you can see that the medulla is still pretty normal, but then the cortex, you can see the zona reticularis of the cortex has expanded greatly. So all of this is too big, and if we zoom in on that, what you see is just normal zona glomerulosa, but it's thicker than it normally is. So the cells themselves are normal, there's just too many of them. So if we zoom in on them, I mean, these are just normal adrenal cortex cells. They're not dysplastic, they're not malignant, but there's just too many of them. So this is an example of pathologic hyperplasia. So we're increasing the number of cells. Now, importantly, hyperplasia is not the same as hypertrophy. So we said hyperplasia is the increase in the number of cells, and hypertrophy is an increase in the actual size of the cells. But as you may have noticed, they both basically just result in the tissue or the organ getting bigger. And so grossly, you can't always actually distinguish between hypertrophy and hyperplasia. So you always have to make sure to look at these under the microscope to distinguish between the two. So is it an increased number of cells, or is it an increase in the size of cells? Or is it a mixture of both? So sometimes you can get a mixture of hyperplasia and hypertrophy. A good example of that is when a woman is pregnant, her uterine smooth muscle will undergo both hyperplasia and hypertrophy so that the uterus can get larger to be big enough to hold the fetus. Another example of that, you can have an upregulation of receptors that can cause new protein synthesis, but you can also have induction of new protein synthesis that can occur as an independent process. So you might have both of these processes happening at the same time, but they are two distinct entities, and you should definitely know the difference between the two. This is going to be the foundation of a lot of different disease processes we're going to learn later on. Now, it's also important to note that hyperplasia is different than dysplasia. So hyperplasia is an increase in the number of cells, but they're still normal cells. So just like we saw on that adrenal gland, if you look at the cells, so you zoom in on the cells, the actual cells themselves look normal. But if they become weird, I guess, with lack of a better word, they become dysplastic. So dysplasia is essentially a precursor to cancerous cells. So dysplasia would be dysregulated growth of these cells, and they're going to be abnormal cells, whereas hyperplasia, it's also an increase in the number of cells, but they're just normal cells. So hyperplasia is not cancer either. Now, you should note, though, that some types of hyperplasia can actually put someone at a higher risk of developing cancer or dysplasia. So an example of that would be endometrial hyperplasia. If a woman has endometrial hyperplasia, she has an increased risk of developing endometrial cancer. So they're not the same, but sometimes they're related depending on the organ system. Okay, next is atrophy. So we did hypertrophy and we did hyperplasia. Now atrophy. So atrophy is kind of the opposite of hypertrophy. So hypertrophy was an increase in the cell size. Now atrophy is going to be the decrease in the cell size. So some people ask, why don't we say hypotrophy? But number one, it doesn't roll off the tongue as nice, but that's just not a term that's usually used, so don't let that confuse you. Atrophy is going to be a decrease in cell size. But importantly, this is going to be decrease in the size of a cell that was at one time a normal size. So atrophy should be, in a once normally developed organ that is now getting smaller. If it is an organ that was never a normal size to begin with, that's different, and we'll get to that in a little bit. So atrophy, similar to hypertrophy and hyperplasia, you can have physiologic atrophy and you can have pathologic atrophy. So physiologic atrophy, this is just a normal physiologic response where a tissue is going to get smaller. So the individual cells are getting smaller. So a good example of this is after a woman gives birth, her uterus will go back to normal size. So here you can see in the middle, this is a fairly normal sized uterus. The rulers are in here for comparison. So this is a fairly normal sized uterus. This on the right, this is a uterus right after a woman gave birth. So this is actually the umbilical cord, the placenta. This is the C-section site, and this is her uterus. So this woman had to have this a hysterectomy because she had uncontrolled bleeding. And so this is the size of a uterus, I think this was about like 35 weeks. So you can see that this uterus is clearly much bigger than this uterus. And so after the woman gives birth, if this was still in her body, this would then decrease its size and go back to normal. So that would be a normal physiologic atrophy. But over time, if you have another type of atrophy, so pathologic atrophy, this is going to be from an abnormal stressor. So this is typically, any atrophy is going to be due to loss of some sort of stimulus to the organ. So is it a loss of blood supply or innervation? That would be like for skeletal muscle, for example, that's a good example. If you don't use it, you lose it, they say, right? So if you're not working out a lot, your muscles may get smaller. Or if you have a debilitating disease and you are bedbound, over time your muscles are going to atrophy because they're not being stimulated. So that would be a pathologic atrophy. Another example would be aging. And so in this picture on the left, this is another uterus. This one is opened. So this one, I know it's hard to tell since I have the pictures the same size, but look at the ruler. This one is bivalved. So this is both sides of it, and it's still only about, probably 8 centimeters long, maybe 10 centimeters long, whereas this is only half of it, and it's about the same size. So this is a small uterus, and this is from an elderly woman who had a hysterectomy. And so after menopause, if you have a decrease in estrogen, then your uterus is also going to respond to that by atrophying. So that's an example of when you remove a stimulus from or to the organ, it's going to respond by atrophying. So pathologic atrophy, like I said, this can happen for a lot of different reasons, but here's a really good example of a kidney. So the kidney on the left is a normal kidney, normal in size, but the one on the right, notice it's a lot smaller. So the one on the right, that patient had blockage or atherosclerosis of the renal artery, which supplies the blood flow to the kidney. And so because it had a decreased blood flow, that led to ischemia, which is decreased oxygen or decreased perfusion going to that organ. And so because it didn't have enough oxygen or nutrients, that kidney, each of the individual cells in there then decreased in size to adapt to the decreased amount of oxygen and nutrients. And so overall, because all of those cells are getting smaller, that's going to cause the organ to also get smaller. And then what the arrow is pointing to is actually a tumor that's an incidental renal cell carcinoma. So the patient had it removed because of the atrophy, but you can see that there was actually a tumor there too. So that's atrophy. Now, this is different than hypoplasia. So I said we don't really use the term hypertrophy, right? It's atrophy. But then there's also hypoplasia. So what is hypoplasia? Well, remember, hypo is going to be like less or not enough, and then plasia we said was growth. So this is going to be not enough growth. And so this is going to be if something doesn't start off at its normal size. So remember, atrophy, something starts at its normal size and shrinks, whereas hypoplasia, it never really starts at its proper size to begin with. So a good example is a renal hypoplasia. This is a congenital condition. So here you can see this is the aorta, these are the renal arteries, this would be the bladder, this is the ureter on each. And so this kidney is fairly normal size. There's a couple cysts on there, but the size itself is normal. And then on this side, this would be a hypoplastic kidney. So it never really grew to its normal size. So definitely understand the difference between atrophy and hypoplasia. Okay, so to recap, we did hypertrophy, we did hyperplasia, and then we did atrophy. Now the last main cellular adaptation is metaplasia. Metaplasia, we said meta is a change and plasia is growth. So this is change from one cell type to another cell type. So this is going to be a change of epithelium at one site from normal, whatever epithelium should be there, to another type of normal epithelium. So it's normal epithelium, but it shouldn't be there. So basically, it is a normal epithelium. It looks normal, but it's in the wrong place. So why do you think this might happen? Well, if you think about an area, say, let's talk about the respiratory system. So if something is lined with respiratory epithelium, it has a very specific purpose, right? You have pseudostratified epithelium with cilia, and you're going to have some goblet cells, and all of that is there for a reason. You need to have that mucociliary escalator, right? But let's say you're a smoker and you're inhaling all of this smoke, that's going to agitate that epithelium. And so this is a type of cell adaptation. So if those cells are being exposed to this smoke, they're going to adapt to that situation, and they're going to change from normal respiratory epithelium to a normal stratified squamous epithelium. So while the cells themselves are normal, they shouldn't be there, so they're in an abnormal place. So that's an example of metaplasia. Another example, a classic example, this one's always on exams, is Barrett's esophagus. So Barrett's esophagus is it's typically when you have GERD. So GERD is gastroesophageal reflux disease. So if you constantly have, let's say, your stomach acid going up into your distal esophagus, your esophagus has a very different function than your stomach. So your stomach is lined with epithelium that is specialized to withstand that stomach acid. But your esophagus, it has a totally different epithelial lining, and so if that acid is going up or refluxing up into the esophagus, that's going to agitate the esophageal lining, that mucosa, and it's going to then adapt to that by changing into a different type of epithelium. So normally your esophagus right here has this nice, smooth, pinkish white glistening lining, and that's going to be just a stratified squamous non-keratinized epithelium. Then your stomach, it normally has this like pinker, it's not as white look to it, and this is going to be lined with a different type of epithelium. So it's going to be, it's going to have the gastric pits, it's going to have totally different types of cells. And so normally right here, you should have a nice straight line at the gastroesophageal junction called your Z-line, right? We've talked about that. So what happens is over time, if you're refluxing that acid up into the esophagus, this epithelium here is going to undergo a change to adapt and withstand that acid. And so it's going to change from its normal stratified squamous epithelium, and it's going to be replaced by glandular epithelium. So this is going to be glandular metaplasia in the esophagus in response to that acid. And so what it looks like grossly is you'll see this jagged Z line. It's not a nice straight line, and on an endoscopy it'll look like these tongues that are going upwards, because remember, this would be closed. And so this would be like a salmon tongue is what we call it, and we'll get into that when we talk about systemic pathology. For now, I'm just trying to demonstrate the change in that epithelium. So here, this would be a normal stratified squamous epithelium that the esophagus should look like, and then if it changes, it's here now changing into this columnar epithelium with lots of goblet cells. So the purpose of those goblet cells is to secrete mucus, and that's going to kind of protect the esophagus against that stomach acid that's coming up. So you should not normally see those in the esophagus. If you see them, then that is indicative of Barrett's esophagus. And importantly, this is just metaplasia, so this is normal epithelium. But over time, if this is chronic GERD, that epithelium can become dysplastic. And then once it's dysplastic, the dysplasia can then eventually lead to cancer. So you can actually get adenocarcinoma of the esophagus, and that can be from long-standing GERD that first was metaplasia, then dysplasia, then cancer. So Barrett's esophagus, while it itself is not cancerous, it is sometimes indicative of the potential of a precancerous event happening. So that's metaplasia. Now, to kind of summarize, we had the 4 types of cell adaptations. We had hypertrophy. We talked about physiologic and pathologic. We had hyperplasia. We talked about pathologic and physiologic. We talked about atrophy, both physiologic and pathologic. And then we talked about metaplasia. Now, keep in mind that you should always be learning by making associations with things. So what do these have in common? Well, all of these are going to be in response to some sort of stress, right? That's the whole point of this chapter and this lecture. But a couple of these have to do with the demand placed on that tissue, right? So if we increase the demand for something, the cells are going to respond by either getting bigger, hypertrophy, or having more cells, so hyperplasia, or it can be kind of a combination of the two. So an increased demand is usually going to respond by hypertrophy and or hyperplasia. Now, if you decrease the demand, that's when you're going to get atrophy or shrinking of the cells, right? So all of these can be physiologic or pathologic. So that's another correlation you should be making. Is this just a normal responsive tissue in relation to some normal physiologic event? Or is it something pathological that is then causing this event? And so, like I said, all of these are going to be in response to some sort of stress or injury. But importantly, notice that metaplasia is off kind of by itself. So metaplasia typically is going to be in response to something pathologic. That's why the normal epithelium is changing to another type of epithelium. But all of them are in response to some sort of stress or injury. So those are the 4 types of cell adaptations.